All right. So a very good evening, everyone. So let me first wish you a happy Dasara. And on this occasion of this particular Dasara, so we should see that all the evil should completely go away from us, and we will invite the entire happiness on this particular occasion. Thank you very much, sir. Good evening, sir. Rajmahendran, sir. Good evening. Thank you very much. Right. So I welcome you all to this particular session. So in this particular session, we will be discussing the clinical based questions. So in order to see that you should not have any difficulty in your upcoming FMGE exams, we at Arise Medical Academy have designed this clinical based discussions every day. So every day in the evening, you will be having the discussion for nearly around 1 hour, in which I'll be discussing around 8 to 10 clinical based questions. And all these sessions of clinical based sessions are very, very important sessions. Apart from attending your theory classes, you should also attend or you should listen this particular clinical based sessions. Now, without attending these particular sessions, I can just definitely tell you it becomes very difficult for you to appear for your upcoming FMGE exam. So please do attend these clinical based sessions. Just attending the theory sessions will not be just enough. You should also parallelly attend these clinical based sessions also, which will be very important for your upcoming exams, right? So with this basic introduction, let me just go ahead and discuss the first clinical based question. Right. So the first question is, we have a 60-year-old male presented with increasing left-sided flank pain and hematuria for 3 months. He has also lost around 5 kg of weight, right? And apart from that, losing the weight, there is also a history of decreased appetite. And on examination, a mass is felt in the left flank, right? And that mass is nearly around 4 centimeters. Which of the following statement is not correct regarding the likely diagnosis of the patient? Anemia is more common than erythrocytosis. Cigarette smoking increased his risk. If tumor is confined to Gerota fascia with best therapy, 5-year survival is more than 60%. If tumor is confined to Gerota fascia with best therapy, 5-year survival is less than 60%. So the question asked is, which among the following is not the correct statement? Right? Not the correct statement. Any one of you? Right. So first of all, you should be very clear with the diagnosis of this case. So can anyone tell me what exactly is the diagnosis of this patient? Right. So if you take the clinical diagnosis of this patient, the clinical diagnosis of this patient is renal cell carcinoma. Right. That is the clinical diagnosis of this patient. Now, why are you thinking it is a clinical diagnosis of renal cell carcinoma? Number one, the presence of mass in the flank area. So in the flanks, no, Chandia, it is not nephritic syndrome. In case of nephritic syndrome, you should have proteinuria, right? You should have hypertension. You should have hematuria. But in our patient, like what is there? There is only loss of weight, and there is also decreased appetite, and there is mass. So one important point to tell renal cell carcinoma is the mass where exactly in the flanks or in the loin area. And along with that, Yes, along with that, the other important feature which is suggestive of your renal cell carcinoma is the decreased weight and decreased appetite. So in malignancy, every one of you are aware that there will be decreased appetite and there will be also loss of weight. So these are the two other points suggestive of renal cell carcinoma. Now, in these patients with the renal cell carcinoma, let me tell you, anemia, right? It is more common than compared to that of the erythrocytosis. And cigarette smoking, yes, it definitely increases the risk of renal cell carcinoma. And if the tumor is confined to Geroda fascia with best therapy, the 5-year survival rate is less than 60%, but not more than 60%. Okay, so the answer is third option. Right, the answer is third option. Okay, so 5-year survival rate, it will be less than 60%, but not more than 60% in a case of renal cell carcinoma. I'll just show you the survival rate among the individuals with renal cell carcinoma. If the individual is in stage 1 renal cell carcinoma, that is the tumor size less than 7 centimeters and confined to kidney, then the survival rate is around 81%. And when the individual is in stage 2, that is when the tumor size is like more than 7 centimeter and confined to kidney, the survival rate is 74%. And when the tumor is in stage 3, where the tumor is confined to Geroda fascia, that is 53%. And what is the clinical question given to us? The clinical question which is given to us is this stage 3. The clinical question which is given to us is this stage 3. And when the individual is in stage 4, distant metastasis, the survival rate, 5-year survival rate is only 8%. Okay. So the question which is given to us is, if tumor is confined to Geroda fascia with best therapy, 5-year survival rate is 53%. That means less than 60%, but not more than 60%. And what is the question asked? Which is not the correct regarding the likely diagnosis of this patient. So the answer is definitely the third option, which is not correct. All right. Now, so this is the first question. Then followed by that, we will take up the next important question. And this renal cell carcinoma, remember, this is more common in males. Right? This is more common in males. And which age group you will see this very commonly is around 50 to 70 years of age. So around the age group of 50 to 70 years of age, this renal cell carcinoma is very common. And our patient is having the age of 60 years. In the clinical question which is given to you, the age which is given is nearly around 60 years. And our patient is a smoker, and smoking is a very, very important risk for the development of renal cell carcinoma, right? Now, among the various types of renal cell carcinoma, which type of renal cell carcinoma is very common? It is your clear cell carcinoma, right? It is your clear cell carcinoma. This is the most common pathology. And what will be the clinical presentation of your renal cell carcinoma? It is your hematuria, abdominal pain, and as well as the abdominal mass. Everything is there in our patient. And remember, they will have anemia, but not erythrocytosis. So anemia is like most common in case of renal cell carcinoma than compared to that of your erythrocytosis. So please remember this point. Next. Yeah. So these are some of the points related to your renal cell carcinoma. Next. Yeah. So this is one of the very important question regarding Yamaguchi syndrome. And let me see how many of you will answer this Yamaguchi syndrome. Regarding Yamaguchi syndrome, the risk of sudden cardiac death is lower than the traditional septal form of hypertrophic cardiomyopathy. Tall peaked T wave in the apical precordial leads in the ECG. Third option, shows a spade-like configuration on the cardiac imaging. Fourth option, most common in India. So they can ask you some questions in a combination. They can ask you questions in combination. So this is a question where the options given are A, B, C true and D false, AC true, BD false, AD true and BC false, ACD true and B false. So regarding Yamaguchi syndrome, so what are the statements which are true and what are the statements which are false? Yes, anyone? So first of all, what is Yamaguchi syndrome? Yamaguchi syndrome, remember, it is your apical hypertrophy of the left ventricle. It is not the septal hypertrophy, it is the apical hypertrophy. No, I did not get the correct answer from any one of you. The answer is B. That means your first option, that is risk of sudden cardiac death, is lower than transitional septal form of hypertrophy, is a correct statement. Then tall peak T wave in the apical precordial leads is an incorrect statement. What they have is an inverted T wave, right? What they have is inverted T wave in the precordial leads and shows a spade-like configuration on the cardiac imaging, right? This is a true statement. I'll just show you this image. And most common in India, this is a false statement. This is more common in Japan. Okay, so your A and C, these are true statements, whereas B and D, they are the false statements, right? Let me just show you now. Now, this is your septal hypertrophy. Right, this is your septal hypertrophy. So where you can make out that septum, it is hypertrophied. But how is this septum hypertrophied? This septum, it is hypertrophied in an asymmetrical manner. It is asymmetrical septal hypertrophy. It is not symmetrical hypertrophy. It is asymmetrical septal hypertrophy, which we call it as ASH. Now, these patients with asymmetrical septal hypertrophy, they have high risk of sudden cardiac death. Right? They have very high risk of the sudden cardiac death. Whereas, what is your Yamaguchi syndrome? What is Yamaguchi syndrome is? Now, as you see, this is your left atrium, right atrium, and this is your right ventricle. In Yamaguchi syndrome, it is the apex of the left ventricle which gets hypertrophied. This is your apex. Whatever I have drawn the blue color line, this is the apex. So only apex it gets hypertrophied, right? The only apex it gets hypertrophied. So this area is your apex. And this apical hypertrophy, this is what is called as the Yamaguchi syndrome, right? This is what is called as the Yamaguchi syndrome. Now, this particular Yamaguchi syndrome, let me tell you, they have less risk of sudden cardiac death. Right? They have less risk of sudden cardiac death, right? Compared to that of the septal hypertrophy. No, it is not the right ventricular apex. It is the left ventricular apex. It is the left ventricular apex, LV apex. Okay, and this is like more common in Japan. And what is this in ECG? You will see, you will not have the tall T wave. ECG in the precordial leads, you have the presence of deep T wave inversions. That is incorrect, like what is given in your option, I mean the third point. So if you take your, the second point, tall peaked T waves will be there in apical precordial leads. This is a wrong statement. What you will have, inverted T waves is what you will have here. Right, you will have the presence of inverted T waves, not the tall peaked T waves, right? So that is a completely wrong statement. Second statement is a wrong statement. Okay, right. So this completes the discussion of about the Yamaguchi syndrome. So A and C, they are true. B and D, they are false statements, right? Now, followed by that, we will move on to the next question. Yeah, and I said you like the spade-like appearance will be there. Spade-like appearance will be there in case of Yamaguchi syndrome. Now, when you do a 2D echo, like this is your spade, right? And if you take the 2D echo of a patient with the Yamaguchi syndrome, this is your spade-like appearance. right? Just similarity of a spade-like appearance. Okay, so this is what you will see in patients with the Yamaguchi syndrome. Next question is a clinical question. Yes, we have a 23-year-old male developed excruciating chest pain and palpitations after drinking 4 cans of energy drink at night while revising for final year exams. So he was revising for final year exams, and he was like he wants some energy, so he started consuming these energy drinks, and after which he started developing excruciating pain and palpitations. And he was brought to the emergency department, and his ECG shows sinus tachycardia, but no ST change. Pulse rate is like 90 per minute. The blood pressure is like 130 by 90 millimeters of mercury. The pain subsided after a short while, right? After some time, the pain reduced. His physical examination was absolutely normal. He gave history that last year his father had myocardial infarction at the age of 60 years. Family history is there. All his laboratory findings were within the normal range. And the troponin and D-dimer test, they came out to be negative. What shall be the next step in the management? Closely observe and monitor. Put him on exercise treadmill test. Do a stress echocardiography. No further investigation is required. Question looks a little lengthy, but if you try to understand the question properly, the answer looks very, very simple. So, summarizing the history, like 23 years old boy, developed chest pain and palpitations after consuming the energy drinks. ECG shows sinus tachycardia, no STT changes. And the physical examination normal, laboratory findings normal, troponin and D-dimer test negative. Okay, so what you people want to do? Chandia wants no further investigation is required. And Madhura wants put him on exercise treadmill test. Okay. Right, so we have a mixed answers. So the answer to this question is no further investigation is required. Right, no further investigation is required in this patient. See, why he has developed all these particular clinical features like chest pain and as well as palpitations. So he has developed this particular chest pain and palpitations because of the consumption of the energy drinks, right? Because of the consumption of 4 cans of energy drinks, that has made him to develop all these clinical manifestations. So this particular patient does not have any STT changes, does not have any laboratory abnormalities, like D-dimer and troponin is completely negative. So we can rule out easily any presence of any disease in this patient. So no further investigation is required in this patient. So doesn't require closely observing and monitoring, right? Put him on exercise treadmill test is a wrong statement. Stress echocardiography is also a wrong statement, right? So the answer is no further investigation is required in this patient, right? Next. See, which group of individuals we consider to keep him on the exercise treadmill test is those individuals, right? Those individuals where they have certain ECG changes, like presence of T-wave inversion, right? So those group of individuals, if you subject them to the treadmill test, then it comes to be positive if there is any underlying coronary artery disease, right? But this particular patient does not have any, right? Does not have any ECG changes. So that will rule out the presence of any underlying cardiac disease, right? Yes, Sagar Dhiman, you are thinking of paroxysmal ventricular tachycardia. Okay. Now you see here, the history is very much apt that after consumption of the energy drinks, he has developed all these symptoms. Now, what does this energy drinks contain? This energy drinks it contains sympathomimetic agents. Right? Sympathomimetic agents. So when the history is very clear that he has consumed some sympathomimetic agents, and these sympathomimetic agents are the one which are responsible for the development of this tachycardia, right? ECG shows sinus tachycardia. Then why you want to subject the patient to any treadmill test or stress test, which is not required, right? Which is not required because the history is very clear that he has consumed some energy drinks, and that particular energy drinks are the one which contains sympathomimetic agents. Okay, right. So the answer is nothing is required to be done in that patient. Right. Now you take the next question. Now, and another explanation for you, Sagar Dhiman. If you are suspecting like paroxysmal ventricular tachycardia, see, I will be happy to tell that paroxysmal ventricular tachycardia would have been there in this individual if the history of that energy drinks is not there. Right? If the history of energy drinks is not there in the question, then I would have suspected any paroxysmal events. But the history is very clear that he has consumed some energy drinks which is containing sympathomimetic agents. For me to think of any paroxysmal arrhythmias is less likely. Okay, right. Now we will move ahead with the next question. So they'll give you some questions. They can give you some of the questions matching the following with column 1 and as well as column 2. So match the following signs of the chest X-ray. So on the left hand side you have the Western mark sign, Hampton's hump, Pallas sign, black pleural sign, and on the right hand side you have enlarged right descending pulmonary artery, a peripheral wedge-shaped density above the diaphragm with convexity towards hilum, area of focal oligemia. Fourth option, the shadow of the pleura between the extensive alveolar calcification and adjacent rib cage. Yeah. So what is the answer? Okay, so until now, like what we have got is two answers. Chandia has answered B and Sai Taruni C. Okay, any other answer apart from B and C? Right. So you take these particular signs. What are these signs suggest you of? In which disorder you will have all these signs? Yes, anyone? Western mark sign, Hampton's hump, Pallas sign. Where do you get these particular signs? In which disorder or in which disease? So let me tell you, these signs you will come across in a clinical condition of pulmonary embolism. Right? So in clinical condition of the pulmonary embolism, you will have all these signs. That is Western mark sign, Hampton's hump, Pallas sign. Now, what are those? Let me discuss one by one. The correct answer here is B. So if you take the Western mark sign, it is an area of the focal oligemia. Right? It is the area of the focal oligemia. Right? And you take the Hampton's hump. You take the Hampton's hump. Hampton's hump, it is an enlarged right descending pulmonary artery. Sorry. Hampton's hump, like what you will have is a wedge-shaped infarct. I'm sorry. So Hampton's hump is a wedge-shaped infarct. Now, what is your Pallas sign? Pallas sign, it is your enlarged right descending pulmonary artery. And black pleura sign, it is the shadow of the pleura between the extensive alveolar calcification and adjacent rib gauge. That is what is called as black pleura sign. Now I'll show you all the signs. I'll show you the chest X-ray of all the signs. Now you take the first one. Yes. So this is your Hampton's hump. So Hampton's hump, what is that you will have? You will have the presence of the wedge-shaped infarct. right? You have the presence of the wedge-shaped infarct. Okay, so that is what is your Hampton's hump. Next, you take the other image. Yes, you see this. There is enlargement of right descending pulmonary artery. So where is it you will have enlargement of right descending pulmonary artery? That is what is your Pallas sign, right? That is what is your Pallas sign. Then you take this focal oligemia. This focal oligemia is what you will see in Western mark sign. So all these, they are suggestive of pulmonary embolism, right? All these, they are suggestive of pulmonary embolism, right? And the only thing you need to remember, the black pleura sign is nothing but the shadow of the pleura between the extensive alveolar calcification and adjacent rib cage. That is what is called as black pleura sign. So in your upcoming FMGE exam, right, you should not be surprised if you get these type of match the following type of questions. So see, from these clinical based questions, and what you need to understand and what you need to learn here is, you should be able to answer the questions very quickly. You have to improve your speed of understanding the question in single reading. That is what is the basic idea behind these clinical based questions. In single reading, you should be able to understand the question and you should come to a diagnosis, then crack the question. So that is the basic idea of these particular clinical based sessions. All right. Next. Now you take the next question. Right. So a 70-year-old male presented with excessive fatigue, fever, and bleeding from the gums while brushing. And on examination, he has splenomegaly. Complete blood picture showed marked pancytopenia with presence of the blasts. And if you take the translocations, you have T1517 translocation, you have Q22, Q12, that is in between the arms, that is Q arm. So you have T1517 cytogenetic rearrangement is found in this patient. Which of the following agents will you use in the management of this patient? Acyclovir, daunorubicin, rituximab, tretinoin. So can anyone tell me what is the diagnosis? Yes, can anyone tell me what is the likely diagnosis in this patient? So this is a case of see, where do you have 1517 translocation? Where do you have 1517 translocation? What is the disorder? The entire question, only one point which will give you diagnosis is that 1517 translocation. Very good, Aniket Raj. So APML, acute promyelocytic leukemia, which is nothing but M3 subtype of AML. So if you can crack this question over, so once you crack the diagnosis, then you should know what is the treatment. Tell me, in case of acute promyelocytic leukemia, what is the treatment you will give in these individuals? Yes, Aniket Raj, what do you want to give in this patient? In acute promyelocytic leukemia, what is the treatment you want to give? No, Rakshita Narayan, you want to give rituximab? No. So the treatment in these individuals is ATTR, that is all-trans retinoic acid. So we give tretinoin, right? We give tretinoin. So tretinoin is the substance what we give in these patients with the acute promyelocytic leukemias, right? Now you see the next question. Yeah. So this is another very important clinical based question, and this is a question which is directly taken from the tables of the Harrison in the general medicine textbook. So a 40-year-old lady presents to the OPD with weight loss and palpitations. Her heart rate is around 110 per minute and blood pressure is 130/70. And there is bilateral proptosis, right? Bilateral proptosis, and there is also warm, moist skin, right? Warm, moist skin. Investigations show undetectable TSH. So the TSH levels are low, and there is normal, right? Normal FT4, free T4, the one which is not bound to the plasma proteins. What is the next best step in the diagnosis? Radioactive iodine uptake scan, thyroid peroxidase antibody scan, thyroid stimulating antibody screen, free T3 levels. Right, so very good. So Sai Tarni and as well as Rakshita Narayan, both of you have answered it correctly. So the answer is the free T3 levels. The answer is you need to check for the free T3 levels. See, what is the clinical diagnosis in this patient? The TSH levels are low, right? The TSH levels are low. So the TSH levels being low with normal T4, this is suggestive of like Graves' disease. Why are you thinking of Graves? Because that bilateral proptosis, you will have that in case of the Graves ophthalmopathy. So it is your Graves' disease. Now, what is asked in your question? The question asked is, what is the next best step? So what is the next best step in this patient is you need to check for the free T3 levels. So we first have to demonstrate the diagnosis of thyrotoxicosis with values of the free T3 levels, right? And if you take the algorithm, right? If you take the algorithm which is mentioned in your Harrison, so I said you, this is the question directly asked from the table or algorithm which is given in your Harrison textbook, okay? Now you see here, I'll not discuss the entire thing, but our patient comes to which particular clinical scenario I will show you. I'll just show you to which particular clinical scenario does our patient comes under. See, our patient is having the TSH being very low, right? And the T4, unbound T4, that is free T4, that is normal. TSH low and unbound T4 levels are normal. So what is the next best step? Next best step is you need to measure unbound T3, that is FT3. If FT3 levels are high, then it is your T3 T3 toxicosis, which is a feature of the Graves' disease. Okay, so this is a table or the algorithm which gives you how you need to evaluate thyrotoxicosis, right? How you have to evaluate the thyrotoxicosis. So you will get the questions sometimes directly from the images which have been given in your Harrison, right? Now, this is one of that particular question. Now, so after that, you see the next question. So You should not have any confusion right now. What does this next step of this particular patient? The free T3 levels, right? Next. Now, sometimes you may get the questions like this. That is reason and assertion type of questions. We cannot expect the questions should be always straight in the upcoming exams. So always you will have questions with some twisted format, right? This is one type of a twisted format of asking the questions. That is reason and as well as assertion type of questions. Now, the assertion is Bloom syndrome, right? Bloom syndrome is associated with increased risk of acute myeloid leukemia, right? Bloom syndrome is associated with an increased risk of acute myeloid leukemia. That's an assertion. Reason, it is associated with mutations in the GCSF receptor and neutrophil elastase. Right, it is associated with the mutations in GCSF receptor and neutrophil elastase. Now, first option, both assertion and reason are correct. Reason is correct explanation for assertion. Second option, both assertion and reason are correct and reason is not the correct explanation for assertion. Third option, assertion is correct but reason is incorrect. Fourth option, assertion is incorrect but reason is correct. Both assertion and reason are false. So sometimes you may have these type of questions, right? And we are trying to give you the idea of how to solve these type of questions, reason and assertion type of questions. So what is assertion? It's a statement. And reason is like that reason should be giving you the explanation of the statement which is given in the assertion. So now assertion is about the Bloom syndrome, right? The assertion is about the Bloom syndrome. So Bloom syndrome is associated with increased risk of acute myeloid leukemia. It's a true statement. Your assertion is correct. But if you take the reason is incorrect. Reason is incorrect. Now why? Then what is the reason you should give? Let me explain. What is the reason you should give? Let me explain. So the answer is C here. Now what is Bloom syndrome first of all? Bloom syndrome is the one where you have BLM helicase gene mutation. What is given in your question? GCSF receptor and neutrophil elastase mutation. It is not your GCSF and neutrophil elastase mutation. It is BLM helicase gene mutation. And because of this BLM helicase gene mutation, there will be defective DNA repair. Right? There will be defective DNA repair. Now, what will be the presentation of these patients? The presenting features will be immunodeficiency. Because of immunodeficiency, they are more prone for repeated infections. Right? They are more prone for repeated infections. And they will have short stature, microcephaly, hypopigmented skin lesions. Right? Hypopigmented skin lesions. And let me tell you, these individuals with the Bloom syndrome, they are at increased risk of acute myeloid leukemia. They are at increased risk of the acute myeloid leukemia. So, to summarize about the Bloom syndrome, it is due to BML helicase gene mutation. There is defective DNA repair. Immunodeficiency and short stature is there. Because of immunodeficiency, they are more prone for repeated infections. And there is increased risk of acute myeloid leukemia in patients with the Bloom syndrome. So that is what, see, this is a question related to your Bloom syndrome. And the basic idea is that they will definitely ask you these type of questions, reason and assertion. So please be prepared with this reason and assertion. Please be prepared with match the following type of questions. Please be prepared with clinical based. Please be prepared with your image based. And please be prepared with multiple options, correct, like these type of questions. Yes. So like these are like multiple options which are correct. So you can have this variety of questions in your upcoming exams. So you should be thoroughly and completely prepared with your upcoming FMGE exam. Next. Now you see the next question. A 42-year female presents with jaundice for 7 days. She also gives a history of itching, icterus, and dark urine. Right? These are the positive points. Itching, icterus, and dark urine. Jaundice is there for 7 days. She denies any history of fever, abdominal pain, or weight loss. Her total bilirubin is 6 milligrams per deciliter, and direct bilirubin is 5. And AST and ALT, they are mildly raised, not grossly elevated, they are mildly elevated. And alkaline phosphatase levels is elevated, and CT scan of the abdomen is insignificant. That means CT scan of the abdomen is normal. Ultrasound shows normal gallbladder, but common bile duct is not visualized. Right? Common bile duct is not visualized. What is the next best step in the management of this patient? Antibiotics and observation, enteroretrograde cholangiopancreatography, hepatic serologies, HIDA scan, that is hepatobiliary immunodiacetic acid scan. Yes, so please make an attempt to answer this question. Okay, so yes, Rakshita Narayan, you want to do HIDA scan, okay? What about others? Okay, so the answer to this question is endoscopic retrograde cholangiopancreatography. The answer is 2. Why? Right? Why is the answer 2? Let me explain. First of all, you take hepatitis serologies. This is ruled out. Hepatitis B and hepatitis C. Right? Hepatitis B and hepatitis C is ruled out. Now, why you have to suspect? Why your hepatitis B and hepatitis C is ruled out? Because of the enzymes. ALT, they are normal. I mean, just raised, slightly raised, and AST is also slightly raised. So, let me tell you, in case of hepatitis, the AST and ALT, they are grossly elevated. So, your hepatitis serology is ruled out. Okay. Now, what about the HIDA scan? Some of you are were telling about the HIDA scan. So, you take the HIDA scan, it is a diagnostic test. And its use, what is the use of this HIDA scan? It will capture the image of liver, gallbladder, bile duct, and small intestine, and it helps to diagnose the medical conditions related to these particular organs. Now, what is our clinical case? Right? What is our clinical case? Clinical picture, it is a case of cholestatic condition. Now, why are you considering it as a cholestatic condition? Right? Why are you considering it as the cholestatic condition? I'll tell you. Why? Because if you see this, you have the features suggestive of the obstructive jaundice. Why? Because you take this direct bilirubin. So direct bilirubin is 5. Right? Direct bilirubin is 5. Out of the total bilirubin, direct bilirubin is 5, which is classically seen in clinical scenarios like cholecystitis. Right? And in cholecystitis, you will also have itching, icterus, and as well as the dark urine. So our patient is having a cholestatic jaundice, and the cholestatic jaundice, whatever is there, is not required to be diagnosed by the HIDA scan. Where do we require HIDA scan? We require the HIDA scan if there is any pathology in the liver, if there is any pathology in the gallbladder, if there is any pathology in the bile duct, if there is any pathology in the small intestine, right? So the clinical picture in this case is consistent with cholestatic cases. In this, there were no evidence of gallstone and clinical polycystitis. So HIDA scan is not required in this case, right? HIDA scan is not required in this case. So what is this you need to do? ERCP. Why? The direct visualization by endoscopic retrograde cholangiopanography can be useful in various causes of obstructive jaundice, like cholangiocarcinoma, tumor of ampulla of Vater, sclerosing cholangitis, and the Caroli's disease. Your ERCP, it is both diagnostic and as well as the therapeutic. So what I am suspecting in this case, I am suspecting primary biliary cholangitis. Right, I am suspecting primary biliary cholangitis. So what I have to do? Anti-mitochondrial antibodies. For specific diagnosis, I will do anti-mitochondrial antibodies. Okay. So to summarize this question, this is a clinical question of obstructive jaundice. Why are you telling that it's an obstructive jaundice? Because the direct bilirubin is elevated among the total bilirubin. And your hepatitis serology is ruled out because enzymes are not grossly elevated. Your HIDA scan is ruled out because there is no direct pathology in the liver or intestine or within your bile ducts. And what are you suspecting? Primary sclerosing cholangitis or primary biliary cholangitis. And what you want to do? You have to do ERCP, enteroretrograde cholangiopancreatography, to directly visualize if there is any presence of ampullary carcinoma and all. And what will confirm your diagnosis is anti-mitochondrial antibody is the one which will confirm the diagnosis. Okay, so this is your clinical question on the obstructive jaundice. Right. Now you see the next question. Next question is a little fairly easy question. A 40-year-old woman with depression and chronic migraine reports with dry mouth and dry eyes. Her primary complaint is that she has no longer eat her favorite crackers. She is unable to eat. Although she does report photosensitivity and eye burning on further questioning. Examination showed dry erythematous, sticky oral mucosa. All of the following tests are likely to be positive in this patient, except SSA, SSB antibodies. She must test SCL70 antibody. What is the question asked? The question asked is except. Anyone? All of the following tests are likely to be positive in this patient except. Okay, so first of all, every time, what is a thumb rule? Give the diagnosis. Very good. So Sai Thorny has given the diagnosis. Very good, Sai Thorny. Now the diagnosis is Sjogren syndrome. Now tell me, which of the investigation is not required for the Sjogren syndrome? Which of the diagnosis is not required for the Sjogren syndrome? Right. Very good, Monica Swami. So the answer is SCL70 antibody. The answer is SCL70 antibody is not required. So SCL70 antibody is required for the diagnosis of scleroderma. Right, for the diagnosis of the scleroderma. Right, your SS anti-Rho is your SSA, anti-La is your SSB. She must test all these. They are required for the diagnosis of the Sjogren syndrome. All these, they are required for the diagnosis of the Sjogren syndrome. Okay, right? But this SCL70 antibody, this is required for the diagnosis of your diffuse scleroderma. So actually, if you take scleroderma, we have two types: limited scleroderma and as well as diffuse scleroderma. In case of limited scleroderma, can anyone tell me what is the antibody for limited scleroderma? For limited scleroderma, the antibody is anti-centromere antibody. For diffuse scleroderma, along with SCL70, we have anti-topoisomerase. Right, anti-topoisomerase. Right. So this is a clinical question of the Sjogren syndrome. So Sjogren syndrome, it's an autoimmune disease, right? It is the antibodies, they will destroy your lacrimal glands and as well as the salivary glands. Because your lacrimal glands and salivary glands are destroyed by your antibodies, these individuals, they'll have dry eyes and as well as dry mouth. Right? These individuals, they have dry eyes and as well as dry mouth. Okay, right. Yes, this is another important clinical question with image based in that. A 65-year-old patient of ST elevation MI underwent thrombolysis with the streptokinase. Right, underwent thrombolysis with streptokinase. The ECG tracing performed after thrombolysis is shown below. What does the ECG exhibits? What does the ECG exhibits? Ventricular bigeminy, accelerated idioventricular rhythm, ventricular tachycardia, Wenckebach's phenomena. Right? No. Anis, it is not Wenckebach's phenomena. So after thrombolysis, if you are getting a QRS complex with absence of the P wave, so it is like wide QRS complex with no P wave. So this is classically seen in case of accelerated idioventricular, right? The rhythm is starting from the ventricle itself. That means the impulse has originated from the ventricle itself. The impulse has originated from the ventricle itself. Now, because the impulse has originated from the ventricle, you don't have the P wave. The P wave, it gets merged with the QRS complex. And even if you take the QRS complex is wide. Why the QRS complex is wide if it is a ventricular rhythm? Because the impulse whichever is originated from the ventricle, it has slow velocity of conduction. Right, it has slow velocity of the conduction. Now, because it has slow velocity of the conduction, you have the wide QRS complex. Right, you have wide QRS complex. Okay, right. And sir, why not VT then? Why not ventricular tachycardia? Because if you take the heart rate there, it is not suggestive of your VT. In case of your VT, the heart rate should be around more than 200. But that is not there. If you calculate the heart rate around in this patient, it is hardly around 60 per minute. Right? Now, this is the one like you will see in a clinical scenario, post-thrombolysis. Right? Post-thrombolysis. Now, actually what will happen is, post-thrombolysis, right, post-thrombolysis, there will be reperfusion of the vessel. Right, there will be reperfusion of the vessel supplying to the myocardium. So initially there was a blockade, and this blockade is removed by your thrombolysis. Now there will be increased perfusion to the ventricle, and now because there is increased perfusion to the ventricle after thrombolysis, this area of the ventricle whichever has received increased perfusion, relatively they will generate an impulse, or that will generate an impulse and will give rise to what is called accelerated idioventricular rhythm. So this is the ECG suggestive of accelerated idioventricular rhythm. Right, now we will discuss this last question and then we will wind up. Okay, we will wind up the session after discussing this last question. A previously healthy 53-year-old man presents to the casualty after he became acutely obtended and had seizure after a marathon. right, and had a seizure after marathon. Immediately, endotracheal airway was established and mechanical ventilation was started. Right, mechanical ventilation was started and endotracheal airway was established. The patient's sodium level is 115 milliequivalents per deciliter. His head CT reveals diffuse cerebral edema with effacement of sulci without cerebral herniation. Which therapy is most appropriate? 180 milligrams of intravenous Lasix, 1 liter of normal saline bolus followed by 100 ml per hour, initiation of the desmopressin therapy, and then administration of the hypertonic saline. Hypertonic saline targeted at increasing sodium 1 to 2 millimoles per hour. Which therapy is most appropriate? Yes, Sai Thorni, you want to give desmopressin? Okay, so if you see this clinical scenario, now the patient has hyponatremia. The patient has hyponatremia. And what type of hyponatremia? Symptomatic hyponatremia. Now, why are you calling it as symptomatic hyponatremia? Because seizures are one of the very important manifestations of the hyponatremia. And this symptomatic hyponatremia, you should definitely treat. You cannot leave that symptomatic hyponatremia like that. Now, how you have to treat that symptomatic hyponatremia is, you need to treat that symptomatic hyponatremia with hypertonic saline. That is 3% saline. Very good, Ishi. So you should give 3% saline. And that 3% saline, you should give at a rate of, that 3% saline should increase the sodium by 1 to 2 millimoles per hour. That should be your targeted therapy. So always remember, if it is like acute hyponatremia, right? If it is an acute hyponatremia, the individual will develop the clinical features like seizures. But if there is chronic hyponatremia, right? If there is chronic hyponatremia, the clinical features will be very minimal. They don't require, right? They don't require the hypertonic saline supplementation in the individual. But if the individual is symptomatic, and what is that which has precipitated the development of acute hyponatremia in this patient? The exercise in associated hyponatremia. Our patient is doing a marathon, casualty after he became upturned and had a seizure after a marathon. So this is what is your exercise associated hyponatremia. Exercise associated hyponatremia will be acute hyponatremia. So in this scenarios of acute hyponatremia, if the individual is symptomatic, please give hypertonic saline, right? So the answer to this particular question is fourth option, right? So to summarize all the questions in 2 minutes, so I'll summarize all the clinical questions in 2 minutes. First question is about renal cell carcinoma. And remember, in renal cell carcinoma, if the tumor is confined to Gerota fascia, 5-year survival is 53%. That is less than 60%, but not more than 60%. And cigarette smoking and hypertension is a very important risk factor for renal cell carcinoma. That's the take-home message of this question. Next. Now coming to your Yamaguchi syndrome. Yamaguchi syndrome, it is apical hypertrophy of the left ventricle. Second point, it is very common in Japan. Third point, risk of sudden cardiac death is less compared to that of the septal hypertrophy. Fourth point, you will not have the peak T waves, you will have inverted T waves. And cardiac imaging, it will show spade-like configuration. That's a correct statement. C is correct statement. Okay. Next. Now, this question, the take-home message is that, remember, an individual after consuming energy drinks, they can have tachycardia, they can have chest pain. Please don't get worried about that. Just, you see that no further investigation is required. Don't do TMT, don't do stress test in this individual. This is a take-home message of this question. Now, take-home message of this question is, like, you can ask questions with match the following with your chest X-ray of pulmonary embolism and their corresponding signs. And their Western mark sign, focal oligemia. Hampton's hump, wedge-shaped infarct. Pallas sign, enlarged right descending pulmonary artery. Black pleura sign, shadow of the pleura between the extensive alveolar calcification and the adjacent rib cage. Right? Next. And the take-home message of this particular clinical question, T1517 translocation. Think of M3 type of acute myeloid leukemia, that is acute promyelocytic leukemia. What is the management? You need to give all-trans retinoic acid, which is nothing but your tretinoin. This is a take-home message of this question. Next. Now, take-home message of this question is that bilateral proptosis with features of hyperthyroidism. Diagnosis, Graves' ophthalmopathy or Graves' thyrotoxicosis. And in Graves' thyrotoxicosis, if your TSH will be very low, and you have to check for the free T3 and free T4 simultaneously. And after that only you have to check for the antibodies and all. Next. Now this question specifically I have put mainly to make you understand that you will have questions like reason and assertion. And this question is on the Bloom syndrome. Bloom syndrome, they have increased risk of acute myeloid leukemia, and the Bloom syndrome is due to the BLM helicase gene mutation. That is a take-home message on Bloom syndrome. Then, obstructive jaundice, please do enteroretrograde cholangiopancreatography. That will give you direct visualization what is the pathology. Right? Next. Yes. Sjogren syndrome, the test what you need to do is anti-Rho, anti-La and Schimmer's test. SCL70 should be done for scleroderma, right? Now, after thrombolysis, if you are getting a ECG with broad QRS complex with absent P wave, think of accelerated idioventricular rhythm, right? Next. Followed by that, yeah, you take the last question. Acute symptomatic hyponatremia, you need to treat the patient with the hypertonic saline. So these are the clinical based and image based, match the following, reason and assertion, multiple answer type of questions in this session. So with this, I will wind up the today's session. And again, I'll see you tomorrow and I'll be there in front of you live to give you a knowledge of the clinical based and as well as image based questions. So until then, good night. Thank you very much. See you tomorrow again.